Good afternoon. We are ready for our final nursing presentation of the day. Woohoo! Please join me in welcoming this group who will be presenting on evaluating community reintegration outcomes in an interdisciplinary wraparound reentry program. And our presenters are Abby Foltz, Karis Lucas, Gabriella Steele, and Jazzy Knight. Let's give them a big round. It's hard to be last.
Good afternoon, everyone. Thank y'all for being here. I know it's hard, we're the last group. But before we begin, we would like to introduce ourselves. I'm Jazzy.
I'm Gabriella.
I'm Karis.
I'm Abby.
Together, we developed the population health project titled Evaluating Community Reintegration Outcomes in an Interdisciplinary Wraparound Reentry Program. Across the United States, more than 600,000 individuals are released from prison each year, according to a 2023 report from the Bureau of Justice Statistics. But what that number does not show is what happens after release. The transition from incarceration back into the community is not just a change in location, it's a complete shift in responsibility. Individuals are expected to manage their health, find housing, secure employment, rebuild relationships, and navigate multiple systems. And that is where the problem begins.
Now that you've stepped into Alex's situation,
Sorry.
sorry.
To bring this to life, we invite you to walk alongside someone we'll call Alex. Alex represents a composite example based on both the literature and what we observed in practice. Alex is a 32-year-old who was released from incarceration this morning. He walks out with no stable housing, no employment, and no clear plan for what comes next. And today, we are not just going to talk about reentry, we are going to experience it. Throughout this presentation, we will follow Alex's journey as he navigates the decisions, barriers, and realities of returning to the community. At key moments, we will ask you to engage in a brief QR question, giving you the opportunity to consider what would you do, what would you prioritize, and what actually leads to success. Because the reality is, success after incarceration is not determined by one decision, but by a series of moments. And for individuals like Alex, those moments begin immediately, often without coordinated support. Community reintegration is a process of returning to society after incarceration. It requires individuals to navigate multiple interconnected domains, including health, housing, employment, and relationships. In this project, we examine reintegration through multiple domains of stability using current evidence and an interdisciplinary approach.
Now that you've stepped into Alex's situation, we would like to hear from you. If you would please scan the QR code and answer the question.
The internet is being slow.
Most of you said getting a job, and that's important because in reality, individuals like Alex are expected to manage all of these at the same time.
Before we move forward, we need to first define a few key terms. First, reentry refers to the transition from incarceration back into the community as described by Miller and colleagues in 2025. This period is widely recognized as high risk, marked by unstable housing, unemployment, limited healthcare access, and unmet behavioral health needs. Next, recidivism refers to whether or not an individual returns to prison or jail following their release. This is the most commonly used measure of data in reentry research and in practice. Finally, justice-involved individuals are those who are incarcerated, recently released, on probation or on parole, or otherwise engaged within the criminal justice system as defined by the National Institute on Drug Abuse in 2022. And these definitions are very important because they shape how we understand and evaluate success during the reentry period. Now imagine this for a moment. Alex has been out for 3 months. He has not returned to jail, However, he is sleeping on a friend's couch, has missed several medical appointments, and is struggling to manage his health. He feels like he's falling behind. So the question now becomes, is Alex successful? And to answer that, we need to take a closer look at how success in reentry is currently measured. Right now, the primary outcome used across systems is recidivism, or whether or not an individual returns to prison or jail following their release. National data indicate that most individuals are rearrested within several years of release, with the highest risk occurring during the early reentry period, as reported by the Council on Criminal Justice in 2024 and the Prison Policy Initiative in 2026. Long-term analysis from the Prison Policy Initiative actually show that over 80% of individuals are rearrested within a decade. Although some jurisdictions report modest declines, recidivism remains a persistent outcome throughout the system. And this is where the limitation becomes clear. Recidivism tells us if Alex returns to the system or not. However, it fails to tell us if he is stable. It fails to capture whether he has stable housing, whether he can manage his healthcare needs, whether he is managing his chronic illness as well, or whether he is rebuilding his life in a meaningful way. Research by Jacob and colleagues in 2023 showed that factors like homelessness and unmet behavioral health needs, which are key social determinants of health, increase the likelihood of recidivism. And while this study does not establish causation, the findings are broadly generalizable and highlight the influence of social and societal factors. So what this means is that recidivism is not just an outcome. It often reflects conditions surrounding Alex, but not his individual behavior. So while he may be improving his health, gaining stability, and rebuilding relationships, the progress is not reflected in recidivism data. Because of this, the literature emphasizes that reentry success must be understood as multidimensional. It encompasses health stability, structural stability, psychological and relational stability, and access to coordinated systems. And that is exactly how we approach this project. To understand what reentry actually requires, we would need to first look at what Alex is expected to manage from the moment he is released from prison.
I want you to picture what this actually looks like in real time. At the moment of release, Alex leaves incarceration with limited money, limited support, and no clear plan. Now remember, he's expected to find housing, get a job, access healthcare, manage his mental health, and rebuild relationships all at the same time. This is not simply individual failure, it reflects a fragmented system. From a systems perspective, this reflects a lack in coordination across healthcare, social services, and community support systems, highlighting the need for interdisciplinary collaboration and nursing leadership in driving system-level changes. And this is what we are evaluating.
Before we move forward, I want you to think about this for a second. Go ahead and scan the QR code and answer this question.
There you go.
A lot of you said navigating the system, and that makes sense because in reality, individuals are often facing more than one of these barriers at the same time. And this is exactly where we start to see gaps in the system, which Ella is going to walk us through using the evidence.
The first piece of our puzzle today is health stability. And for someone like Alex, this is where things begin to feel very overwhelming during the reentry period. Health stability is not just the absence of illness, rather it is the ability to manage both acute and chronic conditions through consistent access to care and support. When Alex leaves incarceration, he is not starting fresh from a health standpoint. He's stepping into a period of significant physiological vulnerability. And the research shows that this isn't just unique to him. There are three major factors that impact health stability during reentry: overdose risk, chronic disease burden, and fragmented continuity of care. Let's start with what poses the most immediate danger to Alex. For Alex, one of the biggest risks in those first few days after release isn't something visible. Rather, it's the sudden increase in overdose risk. A large study conducted by Harding and colleagues in 2023 found that overdose risk increases significantly during early reentry. In fact, that risk is more than double during the first 2 weeks of release compared to later periods. Out of 579 overdoses in this particular study, 65 were fatal, highlighting how critical this window truly is. The heightened risk is largely due to physiological changes during incarceration, including reduced tolerance combined with limited access to treatment and support immediately following release. And this isn't just one study. National data from the Centers for Disease Control in 2024 also confirms that overdose remains a leading cause of death, with disproportionately higher rates among justice-involved populations. But even if Alex avoids this immediate risk, the challenges don't disappear, they simply shift. Like many individuals leaving incarceration, Alex is likely managing more than one chronic illnesses. A prospective study done by Callis and Fiera in 2022 found that nearly 75% of individuals had multiple chronic conditions, and yet almost half did not receive adequate continuity of care following their release from prison. So even if Alex leaves with prescriptions or a treatment plan, there's a very good chance that these plans won't be continued. And we see this play out in follow-up care. An observational study by Easter and colleagues in 2024 found that while some individuals initially access care, fewer than 3/4 of them ever established primary care, and less than half ever attended a follow-up appointment. So for Alex, it's not just about having a diagnosis, it's about whether he can stay connected to care long enough to manage it. Which leads directly into our final issue, one that ties everything together in the health stability realm: fragmented continuity of care. Even when Alex wants to engage in care, the system often makes it difficult for him to do so. A scoping review by Cooper and colleagues in 2024 found that individuals fail to connect with healthcare during early critical months of release. And the barriers aren't subtle, rather they're structural. These include lack of insurance, transportation difficulties, and difficulty navigating the complex healthcare system that we have in the United States. So when Alex misses an appointment or doesn't refill a prescription, it's not simply a matter of motivation. Rather, it's a reflection of these systemic barriers that exist. When we step back and look at the full picture, a pattern becomes very clear. Alex is leaving incarceration with significant health needs, but without a system that reliably supports him in managing them. This instability is driven by both physiological vulnerability and gaps in our healthcare system. And this is where nursing becomes essential. Us as nurses can play a key role in helping patients like Alex navigate this transition. We as nurses can coordinate discharge planning, ensure access to medications and follow-up care, provide education on these chronic illnesses and acute illnesses, and connect individuals to community resources where they are released. In many ways, nurses act as a bridge between correctional and community health systems. In real-world settings, what this looks like often is delayed care for Alex. Without consistent access to primary care providers, he may wait until symptoms are too severe and turn to urgent care or emergency rooms for issues that could have been managed earlier. This leads to care that is reactive rather than preventative, increasing the risk of complications, hospitalizations, and overall poorer outcomes. And importantly, this is not just about individual choice or knowledge. Again, it just reflects a system that makes consistent care difficult to access and maintain. So when we zoom out, the key takeaway from health stability is this: health instability during reentry is not just about illness, it's about access, coordination, and system-level support. Without these systems in place, Alex is left trying to manage complex health needs on his own. And when this piece of the puzzle is unstable, everything else becomes harder. Because even with housing and employment, unmanaged health conditions can still disrupt overall stability. And this is exactly the kind of instability Alex is navigating as he reenters the community. This is where the pieces of our puzzle begin to overlap, because health in and of itself does not exist in isolation. It is deeply connected to both structural and psychological stability. And Jazzy will now explain the next piece of our puzzle, structural stability.
Structural stability refers to access to housing, employment, financial security, which are recognized as key social determinants of health. Building on what Ella just introduced, we begin to see how structural stability plays out in real life through Alex's experiences after release. Even when Alex leaves incarceration, motivated to rebuild his life, the reality is that stability is not guaranteed. Research consistently shows that individuals returning to the community face immediate barriers to stable housing and employment, two of the most critical foundations for successful reintegration. For example, Jacob and colleagues found that housing instability is strongly associated with an increased risk of rearrest, reinforcing how essential stable housing truly is. National reports from organizations like the Center for Disease Control and Prevention and the Bureau of Justice Assistance shows that nearly 44% of individuals are arrested within the first year after release. Nearly 60% remain unemployed, and up to 1 in 5 experience homelessness during reentry. At the same time, reports from the Bureau of Justice emphasize that individuals who lack stable housing and employment support are significantly more likely to experience early recidivism, especially within that first year. For someone like Alex, not having stable housing doesn't just mean not having a place to stay. It disrupts his access to healthcare, limits employment opportunities, and weakens connections to support systems. And this is where nurses play an important role in addressing structural determinants of health through care coordination, advocacy, and population-based practices. Nurses are uniquely positioned to assess these social determinants, advocate for resources, and help coordinate care across systems, ensuring that individuals like Alex are not navigating these barriers alone. To put this into perspective, I want you to take a moment and imagine yourself as Alex. You're walking out after years of incarceration, trying to rebuild your life. The last time you remember paying rent, it might have been around $1,000 a month. But now everything has changed. Housing costs have increased, basic living expenses are higher, and the cost of simply surviving has gone up. At the same time, because of your background, you're more likely to face barriers to employment, often limited to lower paying jobs with fewer opportunities for advancements. So now you're expected to secure housing, maintain employment, and rebuild stability while starting at a disadvantage in a system that has already moved on without you. And for many individuals, this isn't just overwhelming, it's discouraging. So for someone like Alex, this transition period isn't just difficult, it's one of the most high-risk points for returning to the system. At the same time, employment does play an important role in reintegration. Work provides income, structure, and a sense of purpose, all things that build stability. But as Walken colleagues emphasize, employment alone is not enough to sustain long-term reintegration outcomes. Many individuals, like Alex, continue to face ongoing financial instability, including limited financial literacy, unstable income, and difficulty managing long-term financial goals. Without these skills and supports, even small setbacks can quickly become major barriers to maintaining housing and employment. And over time, that financial stress becomes more than just an economic issue, it becomes emotional. It impacts decision-making, increases stress, and makes it harder to maintain progress, even when someone is trying. Program-based research, including work by App and colleagues, supports this, showing that when individuals are provided with both structural support and practical financial skills, they are more likely to maintain stability and less likely to experience rearrest. Similarly, reports from the Bureau of Justice emphasize that comprehensive, coordinated reentry service lead to better outcomes than fragmented approaches. This also highlights the roles of nurses in policy and advocacy, working to improve access to housing, employment resources, and coordinated reentry service at both the community and system level. And research by Davis and colleagues highlights that workforce development and correctional education programs significantly improve outcomes and reduce recidivism when individuals are prepared before release. This highlights an important shift, that supporting structural stability doesn't start after release. It begins before individuals even re-enter the community. It's also important to acknowledge that individuals like Alex are aware that their actions have consequences. However, it would be incomplete and even negligent if we did not also recognize the structural barriers they face upon release. From an ethical perspective, this reflects principles of justice and equity, as individuals are disproportionately affected by structural barriers beyond their control. It also raises concerns related to non-maleficence, as failing to address these barriers can contribute to harm during an already vulnerable transition period. Without access to stable housing, reliable income, and basic resources, individuals are often unable to meet what Maslow would describe as fundamental physiological and safety needs. And also without these fundamental needs being met, it becomes significantly more difficult to achieve a higher level of stability, including mental health well-being, social integration, and long-term behavioral changes. Without intentional coordination and support, individuals like Alex are expected to succeed in a system that is not designed to support their transition. Taken together, the research shows that housing and employment are not just social factors, they are foundational determinants of health and stability. And when that foundation is unstable for someone like Alex, everything else becomes harder to sustain. But even when those structural needs begin to be addressed, stability isn't guaranteed. Because as these pressures build, individuals also begin to experience stress, isolation, and challenges in relationships. And this is where I'm going to transition to Karis, who will walk us through psychological stability and the role it plays in long-term reintegration.
As all of this begins to build, Alex isn't just navigating systems anymore. He's carrying stress, uncertainty, and the weight of starting over. Psychological stability is not just about access to services, it's about connection, trust, and engagement. It's the ability to regulate emotions, stay engaged in care, and maintain relationships over time. When we look at Alex, we don't just see mental health challenges in isolation. We see how psychological stability is deeply connected to every other part of reentry. It affects whether he goes to his appointments, whether he keeps a job, whether he maintains his housing, and whether he continues to move forward or begins to fall back. Because even if services exist, without trust, connection, and continuity, people don't stay engaged. And this is where something powerful comes in. According to a 2025 Gallup poll, nursing continues to be ranked as the most trusted profession in the United States. That matters here, because trust is not just a value in nursing, it's a tool that we can use. And for individuals like Alex, it may be the difference between engaging in care or walking away from it. As nurses, we are often the first point of contact during some of the most vulnerable times in a patient's life. That means we are in a position to recognize signs of stress, withdrawal, emotional overwhelm, sometimes before even a patient even ever says a word. From a nursing perspective, psychological stability starts with assessment. We can screen for depression, anxiety, substance use, and trauma, assess coping mechanisms and readiness for change, and identify barriers like transportation, housing instability, or lack of support. But assessment alone is not enough. What we do with that information matters just as much. We can use trauma-informed communication, approaching patients with empathy, reducing stigma, and creating a space where they feel safe enough to open up. Because many individuals re-entering the community carry experiences of trauma, mistrust, and stigma, not just from incarceration, but from prior interactions with healthcare systems as well. And if that trust is not rebuilt, they're far less likely to return. Hale and Miriam and colleagues suggest that peer support, especially from individuals with shared lived experience, can reduce stigma, build trust, and improve engagement in care. Because when someone feels understood, they are more likely to stay. Nurses also play a key role in education, but not just giving information, making sure it's understood. This might look like explaining medications in simple terms, discussing what to expect after release, or helping patients understand how substance use affects their body now in comparison to before incarceration. Because when patients understand what's happening, they are more likely to engage in their care. Care coordination is another critical piece. Nurses help bridge the gap between systems by arranging follow-up appointments, connecting patients to community resources, assisting with insurance or access issues, and ensuring that there is a clear, realistic plan in place before discharge. Because without that structure, even motivated individuals can still fall through the cracks. Jones and Fellows conducted a study that highlighted gaps in care during this transition are common, and that proactive, structured support can improve continuity after release. And sometimes the most impactful intervention is also the simplest. Taking those few extra minutes, sitting down instead of standing, listening without interrupting, and treating someone with dignity and respect. Because for someone like Alex, who may feel judged, dismissed, or alone, that interaction can shape whether he wants to seek help again or not. Research done by Apple Garth found that individuals experiencing higher psychological distress often anticipate barriers to care and meeting basic needs after release, which can affect whether they engage at all or not. And over time, these challenges don't just affect mental health, they can influence long-term outcomes like stability and even rearrest, as Bales and Picaro describe. So when we step back, a clear pattern emerges. Psychological stability is not just about services existing, it's about whether individuals feel supported enough to even use them. But despite the importance of these nursing roles, there is still limited research that specifically examines how nursing interventions impact psychological stability during reentry. Much of the existing literature focuses on programs, systems, or outcomes, but not always on the human connection that drives those outcomes. So while the research helps us understand what individuals are experiencing, it also reveals important limitations in how these experiences are studied and supported over time. These limitations point to areas where our understanding is still incomplete, particularly in how sustained relationship-based nursing care can influence long-term outcomes. I'm going to transition to Ella, who will walk us through the key gaps in literature and where the future research needs to go.
While the literature helps us to understand the challenges across health, structural, and psychological domains, it also reveals very important gaps in remaining and existing research. One of the biggest gaps is limited focus on long-term outcomes. Much of the existing research focuses on short-term measures, such as recidivism or initial service use, but does not fully capture long-term stability across multiple domains. There are also limitations in study design. Many studies rely on small sample sizes or observational methods, which limits generalizability and the ability to determine cause and effect relationships. In addition, wraparound services are not implemented consistently across different settings. Programs vary widely depending on location and resources, making it difficult to determine which approaches are most effective. And finally, research often examines these domains in isolation rather than understanding how they interact together. Karis is now going to walk us through potential research proposals, that would address these gaps in research.
To address these gaps, future research should focus on longitudinal, multidimensional approaches to evaluating reentry outcomes. One potential research direction would be a longitudinal study that follows individuals for 1 to 3 years after release, comparing those receiving coordinated wraparound services to those receiving fragmented care. Outcomes would not only include recidivism, but also health stability, housing security, employment, and psychological well-being. The goal would be to evaluate sustained stability across these interconnected domains. This type of research would strengthen the evidence base for interdisciplinary care models, support for consistent and scalable reentry programs, and align with the role of nursing and care coordination and population health. And this is exactly what wraparound care aims to do in practice. Abby will now walk us through what that looks like.
Historically, reentry systems have been really fragmented. Different services like healthcare, housing, and mental health are often separated, which makes it harder for people to stay engaged and get consistent support. And this is where evidence-based practice becomes really important. Current research consistently shows that interdisciplinary wraparound care is a more effective approach to reentry. Studies like Wong and Lee Masters show that where care is coordinated across systems, It improves engagement, continuous care, and long-term stability. Research also shows that when systems are really fragmented, individuals are more likely to experience gaps in care and decrease engagement in services. While single domain interventions, like only focusing on housing or employment, can help in one area, they don't address the full complexity. In contrast, wraparound models improve access to care, increase service use, and support long-term stability by addressing multiple needs at the same time. There is a strong evidence that healthcare professionals, especially nurses, play a critical role in this process. For example, APT associates found that individuals who receive support from interdisciplinary, multiple agency reentry teams are better prepared for release across key areas like housing, employment, and healthcare. In addition, research on traditional care programs highlighted in research by Tridler shows how nurses act as a bridge between healthcare and community services. They provide health education, coordinated care, and address both physical and mental health needs. This places nurses at the center of improving long-term reintegration outcomes. Nurses support individuals through education, care coordination, and ongoing follow-up, which helps maintain continuous care during the transition from incarceration back into the community. This is especially important because without structured discharge planning and follow-up, many individuals experience immediate disruptions in care after release. So overall, the evidence shows that nurses are not just part of healthcare systems, but are increasingly part of reentry systems, helping bridge the gap between incarceration and long-term community stability. Now that we've talked about wraparound care and how it brings all of the pieces together, I want you to think about what really matters most for long-term success. Go ahead and scan this QR code and answer this question. Most of you said resources, and honestly, both of these matter because when we think about success, it's easy to focus on resources, things like housing, employment, and access to health care. But what we see in both research and in real life is that resources alone aren't always enough. Someone might have a job or a place to stay, but without support, connection, or people they trust, it becomes really hard to maintain that stability. On the other hand, support alone also isn't enough. If someone doesn't have access to basic needs, so it's not one or the other, it's the combination of both resources and support that actually leads to long-term success. And that's exactly what wraparound care is designed to do. It brings those pieces together instead of treating them separately. And when we look at the evidence, it consistently shows that these kinds of interdisciplinary, coordinated approaches are more effective than fragmented systems. But that also brings up an important question. What does this actually look like in real life? To answer that, we partnered with a local reentry program here in Harrisburg called Gemeinschaft Home. Gemeinschaft is a residential reentry program that supports men transitioning from incarceration back into the community. The program provides structured housing along with support across multiple areas, including employment readiness, financial literacy, health education, stress management, and peer support. The goal is not to just prevent recidivism, but to promote long-term stability and independence. Through our work with the program, we were able to observe how these services are actually delivered in practice. And what we saw directly reflected what the research describes. When systems are connected, individuals are more likely to stabilize and stay engaged. This is something we saw directly in our work. Through our sessions, many of the men expressed uncertainty around budgeting, credit, and financial planning. And when given the opportunity, they actively have engaged in learning these skills and applying them to their own situations. At this point, we'd like to share a video of the men themselves.
When we step back and evaluate reintegration outcomes, we do not see one problem, we see a system. Individuals are not failing, systems are failing them. From a systems theory perspective, oh, I don't want to get emotional. Oh. Yeah.
From a systems theory perspective, this highlights how breakdowns across healthcare, social services, and correctional systems directly impact outcomes, showing that reintegration is not an individual issue, but a system-level responsibility. The evidence consistently shows that stability during reentry is influenced by interconnected health, structural, and psychological factors. Wraparound care brings those pieces together, making stability possible. Alex is not one person, he represents thousands of individuals navigating reentry every single day. We also want to take a moment to acknowledge the Gemeinschaft home. Miss Jenny is one of the staff, and she's here today, and we're so thankful for that. This project was not just based on research, it was built through real conversation, real experiences, and real trust. We didn't just study reentry, we sat with people who lived it. We heard what it feels like to start over with limited support, limited resources, and everything on the line. And that changes how you understand this work. So to the staff and the Mennonite Gemeinschaft, we just want to thank you for allowing us to learn from you and for trusting us with your stories. Because reintegration is not just about returning to society. It's about whether someone is given a real chance to stay. So now we'd like to open up the floor to any questions that you all may have. Oh my God. Oh no.
Thank you very much. What questions do you have for this group? I have Candy.
I don't have a question, I have a comment. I'm a case manager at the Gemeinschaft Home in Harrisonburg. And I just want to say I'm very impressed with the ladies that came to the Gemeinschaft. You all did an excellent job. And the gentlemen gained so much from you all's presentations and giving them life experiences. And we appreciate you all so much.
Oh, thank you, Jenny. We appreciate you.
I was just wondering, what some of the most impactful things that you experienced or learned while working with formerly incarcerated people.
Mm-hmm.
I can, yeah, or go ahead. Okay. So I think the whole experience in and of itself was extremely impactful for me because I went into it a little bit intimidated because I didn't know what to expect and I didn't know how they were going to receive what we were offering and how engaging they were going to be. But walking in and just seeing the life that every single one of these guys has been or have lived, and looking in their eyes, you see the genuine soul that they are, and it was just a beautiful experience because I also had a subconscious bias of well, addiction is strong, yeah, but if you have family and you have, people who support you, but yet you keep falling back into the same, why? It was frustrating to me to think about it that way, but after seeing, the benefits and the resources that these guys have that are lacking and how strong addiction truly is, it just was eye-opening to me, and it kind of took that bias away that if I was in their shoes and I didn't have the resources that they had, I can't say that I wouldn't do the same thing and fall back into the same pattern. So just the guys as a whole, it's definitely changed my perspective on prejudgment and not judging from an outside, but they're all such beautiful people, and I think that was really impactful for me.
I want to bounce off of that real fast just because I know Wendy's not here, but I remember in level 1 One thing that Wendy taught us from the very beginning is to be careful using the word non-compliant. And I think that really applies in this situation. As someone who comes from a background where substance use affects your life, I think, like Karis is saying, you have the perception, like you've gone to jail, you've now gone through sobriety, why not just stay there? So it's not a matter of like non-compliant, it's a lot of other outside factors that you can understand after meeting some of them, why it makes more sense to just stay where they're staying. So I just wanted to note that. I know Wendy's not here, but lots of value in and not using the word non-compliant in this situation.
This is not a hard question. There are really hard questions at this moment. But I thank you so much. This was an excellent presentation, and I learned, you said a lot of things that were new to me that I learned. And one phrase I think I'll remember is that as nurses, we're not just part of the healthcare system, we're part of the reentry system, which you could take several ways. I took to mean that as nurses, we take care of everybody. And so we will be taking of individuals who are reentering post-incarceration. But I was wondering if you came across any reentry programs, wraparound programs, in which there was a specific role for an RN just to work within that system.
Within our study, we actually found that California is the only state that actually will implement a nurse and allow that nurse to solely stay in that position. I think we've gone through clinicals, or some of us have, where we've gone to jail settings and nurses are just used to treat and triage. And I think in the hospital setting, we see where the resources are stretched and nurses are pulled as social workers and shrinks by the time it's done and everything else. But evidence has shown New York is trying to implement it. I'm sure a lot of it, Kate and I we all spoke with Kate about it, is resources are the main problem. But California is the only state that we could find any evidence that actually will use the nurse, which I think is great because scheduling, getting to an appointment with a psychologist is hard, few and far between. It might take a long time, and it's nice that that nurse can be used as a mediator in the meantime, especially for individuals like this who are so fragile in the early year, to keep them on the straight and narrow path.
Yeah. Even just from an educational standpoint too, to be able to sit with men or women and educate them on, their health conditions or preventative care, because a lot of the guys that we worked with didn't understand a lot of the things surrounding prevention. And so just even to educate, to be able to help them during this fragile time, I think would be beneficial in addition to doing, the more nursey things that we may think of, and the more task-oriented things.
Thanks. As you're talking, I'm thinking gosh, all the research that supports home visiting nurses with young families. Wow,
Yeah.
that's all actually applicable to
Yes.
this population. Thank you so much for a beautiful presentation. Let's give them
Sorry.
another round of applause. Thank you all for sticking it out today. Please make sure you scan out with the QR code for nursing students. And if you want engage points, check in with Laura at the back. Have an awesome day. Thank you.